3 years ago, it became apparent that there are certain behavioral health needs that there are really well-trained people in the world, right, in our community, who are geared right for it. Through a pilot project with the BCN, Joy Mauldin joined our group, and we kind of let it grow organically, and it became apparent within 2 weeks that we needed more of them. So in our work with that project, they helped to backfill, if you will, the financial piece of it, because it's untenable right now, of course. So they provided funding so that we could get the program started. And it was incumbent upon us then to figure out how to bill, how to use them efficiently and appropriately to try to maintain a program that could stand on its own.
We have somewhere between 15 and 16,000 active patients here at Childhood Health. It's definitely a county, like many counties in Oregon, with high poverty rates, high incarceration rates, a lot of kids in foster care.
When you talk about, though, who are the users of the behavioral health program here, while we have this mixed demographics that do reflect our community, the folks who have benefited from behavioral health interventions have been everyone from every spectrum. And what I like best about doing this in a pediatric environment is that I believe that if we make interventions early on, that small steps along the way, just sort of quick fixes that you can sort of address kind of patient, our parent-child communication issues and things like that, that you can lead to better outcomes in the future.
The receptionist checks in the patient. We see it on our computer. We room the patient, take them back, gather information, and then take vitals. And as we come out of the room, we pull out a blue flag. For us, that means that we're MA or nurses in there rooming a patient. And once we're done, we're completed that and sent the chart to the doctor, we pull out a red flag. And the red and blue means they're ready to go.
We also are a clinic that uses team-based care. In each shift, all of the medical staff, including us, are based in what we call a pod, and then we use that as sort of our home base in between patient encounters. And so we're in there all together with the medical staff, the nursing staff, the MAs, and so we're able to communicate in between patients. And we also are using the medical record. We use all scripts here to communicate back and forth. And then we have the health record that we use is integrated, so everyone can see everyone's notes in the same record all of the time. And on any record that we create is copied to the primary care provider for that patient after each encounter.
There are a couple different ways that we work with behavioral health here at Childhood Health. We're seeing a patient and they have some issue that they'd like to discuss further, and it seems appropriate for them to see a behavioral health person. Then we'll have them make an appointment with behavioral health, and then they'll come back at a later time and visit with them.
The providers will refer a variety of symptoms and issues for us, everything from encopresis and tantrums and bedwetting to biting to suicide and depression. So we're available on the floor in our assigned appointments. So I think our role is to integrate behavioral health in any possible moment. We have 2 schedules. Dr. Lambert and I work reverse schedules so that there's behavioral health on the floor all the time. So our schedules are from 8 to 2 and 2 to 8. And then I'm scheduled every 30 minutes. And if there's a cancellation or a no-show, then the providers will come and grab me for a warm handoff. If there's a crisis, they come and get me. So I can often see 10 to 12 patients in a shift.
We have scheduled appointments, but we're also seeing walk-ins, urgent appointments, and on my schedule I maintain triage appointments. And so our nurse high priority nurses are taking triage calls from parents all the time, and so they can schedule a same-day appointment as well for an urgent need. So we're really trying to make sure that there's access all the time.
Every appointment, there's screeners that are given, the pediatric symptom checklist, the CRAFT. We often do a PQ9 for depression, scared for anxiety, and those are scored by our MAs and placed into the EMR. So we have a baseline of symptomology. I have patients that I have, like, say 10 of them, and I can go back through the EMR and see where they were when they first started and then where they are now. And if there's been changes, and I make notes of that in every note. If I see a patient or Dr. Lampert sees a patient and we feel like they need an outside referral, then I'll make a referral through our Allscripts EMR process. And there's a lot of touches that we use to make sure that the patient is getting into mental health services. We have found that the more touches for the kind of population that we serve, the better outcomes we get. We started at 12% getting into mental health services, and now I think the numbers show like 66%. It's phenomenal.
We've given the behavioral health team a lot more responsibility, and we've relied on them a lot more to sort of deal with some of these behavioral health kinds of concerns, and it's been tremendously helpful. They help to sort of manage the outpatient referrals for people who need ongoing therapy, sometimes helping to find people who do medication management, although we're trying to bring that in-house as well.
We've grown a lot here and added in the behavioral health part, and it's worked out though. Every day, I mean, you see it on paper, we have these many providers here, we have these many rooms, and sometimes it's a little bit stressful, but it works. We always make it work, and we work as a team here.
When you're thinking about how do you build an integrated behavioral health model is, one, you do need the commitment. We're also going to, realize that we're probably not going to get it right the first or the second or the third time we attempt something. That this is a process that we continue to focus on how can we make this work better.
The first thing, you have to get buy-in from the providers. They have to understand the need for behavioral health, and this is a very new thing. To interfere with their flow, their coveted time, their patient care. 70% of people come in to primary care for mental health. So to have the provider understand the value of behavioral health, and then how it's going to actually help their patient care by expanding their practice and taking some burden off of them.
How my practice has changed with having them here is just even my own professional development and training. So it's awareness of what's going on in my patients' lives and having a lot more strategies on what to do about that. Either something as simple as deep breathing, and how do you talk about that with a young child for a problem with anxiety. Every time I share a patient with one of the behavioral health folks, we see a copy of every note that they do and sign off on every note that they do. I'm learning from all of this.
It's difficult, I think, for pediatricians because we don't have a lot of training in our residency programs with dealing with behavioral health issues. So it's great to have somebody who's on the team, who's there in the building with you, following you around, knowing your same patients. So there's sometimes when we have problems that present themselves that we don't have a lot of experience with, but that the behavioral health people do. So it's really great to have access to that other set of training and experience.
They support me, They speak Spanish because my English is really bad, so if I need something, they always call. I just, don't worry, we have somebody speak Spanish, run away,
There's a lot of continuity that it breeds by having the behavioral support person as well as the primary care doctor in the same office and being able to communicate with each other. It's the best system I've ever seen because you have two people working for you and all of their support people that are reminding them gently to work for you. It feels so good to have somebody that I feel like is on my side. This person knows my story, remembers things, follows up with me. It's been tremendous.
We're building it from a different perspective. Rather than saying, the first thing that we'll do is the medication. What we do here is the first thing we do is, you need some behavioral health interventions. And the behavioral health team can help us to figure out, do we need some long-term counseling and some other kinds of supports, parent-child interaction training. We're approaching it from the non-medical perspective first. And I think that leads to better outcomes.
If you're thinking about doing this, do it. You will never go back. I would never work somewhere that did not have that.